So I would really have patients ask their doctors, those sort of questions, make sure they have experience with it. I would certainly consider getting second opinions and make sure the prices that you're paying for these, because we hear stories about people paying, $10, $15, $20,000 sometimes for these injections, which honestly, it's just more than I think anybody should be charging based on the literature available. So these are all important things to be looking at. And if it doesn't feel right to you and you don't really get the sense that you're in the right place, then you're probably not. And you should probably get another opinion.
PM&R podcast is for information, education, and entertainment purposes only. This applies to all information, graphics, videos, and content on the affiliated website and podcasts. The aforementioned does not constitute medical advice, nor does it establish any patient-physician relationship. The information and content on this website do not substitute for any professional medical diagnoses, treatment, or advice. Seek advice from a qualified healthcare practitioner for any questions you have concerning a medical issue, including treatment. Do not delay consultation with a professional or disregard their advice based on the information on this website or podcast. The opinions, statements, and views are that of my own and do not reflect those of my affiliated institutions, policy, or any entity.
Hello and welcome to World of Pain MD podcast, where we discuss all things pain with the experts. I'm Dr. Derick Davis, a physician specializing in pain management. In this episode, we speak with Dr. Kenneth Mautner about orthobiologics and ultrasound in MSK medicine. Dr. Mautner is from New Orleans, Louisiana. He attended Washington University in St. Louis for undergraduate and completed his medical school at Tulane University back in his hometown. He did his residency in PM&R at Emory, followed by a fellowship in sports medicine at the American Sports Medicine Institute. Dr. Mautner has held multiple notable roles, including serving as the Sports Medicine Fellowship Director at Emory University and the head team physician for the Atlanta Hawks, as well as a team physician for the Atlanta Braves. His contributions to sports medicine and orthobiologics are immense, with dozens of research publications and 2 co-authored books, Atlas of Interventional Musculoskeletal Ultrasound and Musculoskeletal Physical Exam, an Evidence-Based Approach. Orthobiologics has taken off as a field. However, there are many hang-ups and obstacles, the likes of which Dr. Mautner discusses in this episode. I'm looking forward to the inevitable progression of this subject matter given its significant potential. Anyways, thank you so much for watching or listening. I hope you enjoyed this episode and learned something. Dr. Mautner, thank you so much for your time. Thank you for coming here. Welcome to the show, World of Pain MD, where we discuss all things pain. Thanks, sir.
Thank you. Thank you for having me.
Yeah, of course. So I think we'll just jump right into it and start talking about ultrasound and orthobiologics. So you were an early adopter of ultrasound for MSK medicine and in the field of orthobiologics. I was just wondering how you found yourself interested in both of those.
Yeah, so I started doing ultrasound in 2007, but you're right, it was kind of on the early end of a lot of sports medicine physicians doing ultrasounds who kind of adopted it at that time. And, what I found is prior to that, my ability to get people better was limited to rehabilitation, steroid injections, tincture of time, and I just felt like it wasn't enough.
Yeah.
And there were around that same time that there started being some studies and people in the sports world talking about some of these procedures that were being done that could help to maybe, heal tissue and actually regenerate tissue, or at least make these tissues stronger and maybe actually make people actually better and have them be able to come back stronger than they were before.
Right.
And it just made a lot of sense to me. And so being on the cutting edge of it, I got to do a lot of these things kind of early on before a lot of people were doing it. And then everything is kind of just built up from there. And now finally some of the research is starting to kind of back up what we've been doing for a long time.
Right. So 2007 with ultrasound, and like the earliest publication I could find with you in orthobiologics was 2011, but you were a little bit before that, you'd say?
Yeah, I started doing orthobiologics probably early 2009. But you're right, the first publication, which I think was a case series on ultrasound that guided PRP for tendon issues. Yeah. And basically a large case series that we had collected between me and a few other doctors around the country. Mm-hmm. And it showed that about 80% of the folks that we injected actually did well with getting an ultrasound guided PRP injection.
What were some of like the struggles you had initially when you started up doing ultrasound orthobiologics?
Well, initially, we didn't even have a machine or anything to process PRP. So now there are 15, 20 different companies who make these PRP products, and you can just take blood and put it in the centrifuge and spin it. The first time I did this, I used one of those old science centrifuges that we used to use back in middle school, and I had 6 individual little test tubes in there, and I put blood in the 6 test tubes, and then I spun it. I had to look up how to do it. I took out a little portion from each one, and then I injected the Buffy coat that I had from multiple test tubes into the patient. And she did really well. It was a professional women's basketball player who was the first PRP injection I did, and her story's actually been documented online because she had this patella tendon issue for a number of years. And so initially it was really that a lot of people didn't know what this stuff was. And trying to figure out, how to do it, what were the proper rehab protocols, because really nothing existed back then. How were these patients going to do long-term with this? So there are lots of challenges. And then just in terms of even educating patients. And so, nowadays, every day in my clinic, I have people coming in and asking me about these treatments. But back in the day, like very few people outside of professional athletes even knew what they were.
What about ultrasound?
Yeah, ultrasound, I remember I started at Emory in 2004, and one of my mentors from residency, and then when I started, was a guy named Michael Shoffley, who's a pain physician in town still, who was an Emory physician at the time, and he was telling me about how over in Europe they were using ultrasound in sports medicine, and when I came to Emory, he's like, you really should look into this. And of course, I was super busy starting a new practice, so it took me a couple of years until I took a course on ultrasound. And I got hooked right away on that. It's amazing what a game changer it's been for the field of sports and musculoskeletal medicine, to be able to have a point of care device where you make diagnoses and guide treatments, all at the bedside, with this tool that has, evolved as well in terms of just the ability to see things and see things more clearly. And the technology and ultrasound have made the pictures unreal over the last 15, 16 years. So once again, the battles initially with that were, how do we get my department to pay for an ultrasound machine? How do I bill for ultrasound? How do I make sure insurance companies understand that I'm not a radiologist, but I can do ultrasound? And then how do I use it to benefit our patients that we treat?
Sure. So compared then to now, what are you seeing that you're pretty impressed with and that you couldn't do back in the day when you first started with ultrasound and orthobiologics, maybe together or separately?
So I would say that with the technology of ultrasound, the ability to treat nerves has vastly improved. Back in the mid-2000s, I don't think we really had the resolution to see nerves nearly as well as we do these days. And so, doing procedures for, chronic nerve pain, whether it's hydrodissections or, guiding, radio frequency or cool leaf burning type procedure to the nerves, all those things have probably evolved quite a bit with the advent of better ultrasound machines. I think that initially there were no tools or devices available. And so all the tools that were made by these big companies were made for orthopedic surgeons. And there weren't any tools available for guys like you and I that we could do in our office, because some of these procedures, like treating doing a tenotomy or debridement of a tendon, doesn't need to be done in an operating room. We can do it cheaper, more efficiently, with less pain, less invasive, and probably get equal or better results if we have the right tools. And so over the years, very slowly, these tools have been developed. And now, hopefully, over the next 10 years, there'll be even more tools developed to help, do more bedside procedures.
When you see patients in clinic, how do you explain what orthobiologics are, orthobiological medication is?
Yeah, so orthobiologics is basically using a biologic agent or a natural agent that can aid in the relief of pain and improve function in our patients. And so I don't like to use the word healing or regeneration as much as I can, because I think that gives false expectation to patients that, this treatment is made to heal or cure your disease. And I'm not saying that we don't have some ability to do that, but I think the whole point of orthobiologics is to use these natural agents to help injury recover faster, improve the function of the patients, and allow them to get back to their sports and activity they want to do with less pain.
The Journal of Orthoscopic and Related Surgeries recently published this article, which you were part of, trying to achieve this consensus about how we define PRP for MSK pathology. It didn't really seem to have much of a consensus of how we actually define it. And I was just curious what your operating definition of PRP is in terms of, it seems like it was pretty consistent in terms of asking about levels of leukocytes, or this was what it was not consistent about, is that asking for levels of leukocytes or platelet count. So do you have in your mind how you define what PRP is?
Right. So PRP stands for platelet-rich plasma, right? And so the old definition that people used to use was any concentration of platelets over your baseline, whatever would be naturally in your blood, would be considered platelet-rich plasma, or PRP. I think that as we've evolved, if you really want to call something PRP, I've started using the definition that it should be at least two times the amount of platelets that's in your blood. So, for example, an average person may have 250,000 platelets per microliter inside their blood, and so for PRP, you'd have to get it to at least 500,000 platelets per microliter, and there are a lot of classification systems looking at PRP that do look at the amount of leukocytes and the amount of red blood cells, and sometimes even breakdown of the leukocytes between neutrophils and lymphocytes and monocytes. And so part of the problem, or actually one of the biggest problems with orthobiologic medicine in general, is that we're creating a treatment that we're putting into patients, but the treatment's not uniform. Mm-hmm. And so the PRP that I put into you or me from my blood or your blood may be very different. And even my own blood today may be different than what my platelet counts would be in a week when I'm doing the same procedure. And I think that has significantly held the field back.
Yeah. No, we've discussed that before. So are orthobiologics and regenerative medicine, are they the same term? Are they synonymous, or do you see them differently?
No, so orthobiologics is underneath this umbrella of regenerative medicine, and so so there is a defined field of regenerative medicine, which involves not just mesenchymal cells and PRP stuff that we're doing that are part of orthobiologics, but it also involves true induced pluripotent stem cells and culture and expanded cells. And even, third-party embryonic stem cells that are used to regenerate, for example, cardiac tissues or other areas of medicine. Mm-hmm. So orthobiologics is kind of the area of regenerative medicine that deals with orthopedic patients.
Okay, got it. So when you see a patient with an MSK complaint, where do you have orthobiologics fitting into your algorithm for treatment? And I know, you at this point in time kind of have a biased patient population because you're known for orthobiologics. So you're already getting patients to clinic, but sometimes you get new patients that are referred to you, and maybe they're not even aware of what orthobiologics are. So how does that fit into your treatment algorithm, whether or not you bring that into play, I suppose?
Yeah, it's a good question. It really depends on what they're seeing me for. And so I guess we can break it down. Do they have a tendon issue or like a joint issue? And so I still, like you said, I have a very biased population, but I'm still do a lot of bread and butter sports medicine and orthopedic care. So I still do believe in kind of foundational treatments of MSK complaints, which involve, potential lifestyle modifications, including weight loss and nutritional support. There's some supplements or medication that can sometimes help with pain. And obviously, I'm a big proponent of physical therapy and rehabilitation and exercise as the form of treatment for a lot of these complaints as well. We know now the patient needs to move if they want to get better, and being sedentary is not the answer for most any thing that comes into my office. Depending on how much of that they've tried, dependent on how significant the pathology is that I'm treating, whether it's in a tendon or a joint, I may move up the conversation for different sorts of biologics earlier rather than later. And, there are some biologic treatments, for example, hyaluronic acid injection, which is considered a biologic, or, just doing a needle treatment of a tendon that are relatively cheap and are covered by insurance. But the other barrier is that some of the treatments that I do outside of some studies that I'm involved with are not covered by insurance, and patients have to pay for them, which adds a whole nother layer of complexity and probably isn't an equitable healthcare issue that we're dealing with today, but unfortunately is real life at this point. And so we need to factor that into the conversations about when and where they might be applicable.
Makes sense. Are there any contraindications that you discuss or that you try to find?
So there are certain areas that I just don't think orthobiologics helps very much. And some of that is based on literature. Some of that is based on me doing this for 16 years. For example, if someone has advanced hip osteoarthritis, I've not found very good success with orthobiologics for that. And we have very good success with doing a hip replacement. Mm-hmm. And so I would say I turn down more people, or I tell them it's not appropriate more than it is appropriate for patients, who kind of fit that description. Mm-hmm. If people have any active infections or significant rheumatological disease or other medical comorbidities or certain forms of cancer in their recent past, we may want to at least check with other physicians, get clearance before proceeding with an orthobiologic injection.
How much is education at play when it comes to expectations for doing your orthobiologic procedures in terms of educating patients about the post-procedural elements and then just what orthobiologics are?
I mean, it's a lot because there's a lot of misinformation out there about orthobiologics. There's a lot of this stem cell tourism industry that has really, taken off over the last 10 years. And it's finally, I think, maybe reached its peak and hopefully starting to get a little bit better. But, people can read billboard signs and look on the internet and they can see all these things talking about curing their disease and before and after x-rays that show, new cartilage formation and all these things going on. And honestly, the literature just, especially in this country, just doesn't bear out that the treatments we do are doing those things. Mm-hmm. And so I always, preface a procedure I do with having realistic expectation and in a true informed consent conversation where, I tell them my goals are to reduce your pain and improve the function, regardless of whether or not, there's any changes to the joint itself or to the tendon itself, which may or may not ever happen. And in fact, especially when we're talking about osteoarthritis, rarely do we see any significant changes on imaging when we look at them down the road, even when people are doing fantastic. So yeah, I think that's a really important conversation to have with your patients. Whether they want to hear it or not is a different story. Whether they listen to it, because I still get folks down the line who are asking about whether it did what I told them it probably wouldn't do. But I think that one of the things that I try to impart upon residents and fellows and other people in my clinics is that's the most important part of the procedure, is having those conversations and picking out who the right patients are. It doesn't take a lot to train someone to draw blood and find a place to inject it, but really, guiding the patient through the procedure is where I think the art of this comes.
You kind of already mentioned this, but are there any other misconceptions that come up regularly? I mean, like regrowth of cartilage, regrowth of bone, regrowth of muscle, things like that. Are there any common misconceptions you see or hear that you'd like to address with both patients and providers, I guess?
Yeah, I mean, I think those are the main ones that we talked about before. I also think that a lot of providers out there, as well as patients, have unrealistic expectations in terms of the timeline of how quickly or not quickly these things get better. And so, when I do a PRP injection, you may not see any improvements in patients at all for 6 or 8 weeks. And it could be 3 to 6 months for one PRP injection to have its intended effect. And, a lot of kind of naysayers of PRP will tell you, well, that doesn't make any sense. It's just natural history. But, it's following the course of how wounds heal and how tissue heals. And so studies have consistently shown that, between 6 weeks to 3 months, there starts to be improvements. And from 3 to 6 months, there continues to be improvements and even more improvements. And so I think for patients and providers to have patience with their patients, I think that there is a need for some good rehabilitation to kind of work on strengthening the muscles and tissues directly involved or around the area that we're treating. And I think that will affect our outcomes as well.
Could you briefly, and this is a topic that we could probably talk about for an hour in and of itself, or probably longer, but how PRP and things like medicinal signaling cells, or I guess what used to be called mesenchymal stromal cells, how they actually work?
Yeah, so it's a good question. And honestly, I don't think the mechanisms are too different, right? And so inside of your platelets, I'll start there. Inside of your platelets are these granules, and inside of these, we'll call them alpha granules, are where the proteins and these cytokines are released. And so the cytokines and proteins inside of your platelets create both pro-inflammatory and anti-inflammatory cytokines. And depending on the environment in which they are injected and put into, they could probably have either or both effects. And what I mean by that is when you inject PRP into a tendon, we're actually trying to create a little bit of an inflammatory response in the tendon, and therefore putting PRP that may induce a little bit of inflammation is probably a good thing, which also goes to the point of why we may want to have some lymphocytes or monocytes or some white blood cells in there as well to create this kind of healing environment inside of a tissue. Whereas if you put PRP into a joint, you want inflammatory cells that will reduce inflammation or cytokines that will reduce inflammation, IL-1 receptor antagonists and things that are anti-IL-6 and other things like that. So that's how PRP works. And with medicinal signaling cells, or what we used to call mesenchymal stromal cells, these are cells that sit on red blood cells and something we call pericytes. And so they're naturally occurring in our body. And the hope and the goal is if you concentrate them and inject them into an area, they will also induce a signaling response with these interleukin and with the platelets and allow, they may have a little of a better ability to kind of prevent cell death and prevent something called apoptosis of cartilage cells, but they also suppress inflammation and have this kind of natural anti-inflammatory effects in tendons or joints when they're injected. So in a nutshell, that's kind of how it works. It's obviously a lot more complicated. I'm not a cellular biologist, so forgive me if I didn't explain that to people's satisfaction.
It's a very there's so many, there's book chapters and so many articles published on it. Do you have a particular patient for either the PRP or BMAC or the adipose-derived medicinal signaling cells that you feel like just knocks it out of the park each time? They're like, this amount of arthritis in this joint or this tendon with this thickness or damage, I'll use this for, and it does really well?
Yeah, I think there's probably several things we treat that tend to do really, really well, and it does follow the literature. I think pretty consistently when we treat patients with mild to moderate osteoarthritis with PRP and the usual amount of time with one PRP injection, occasionally we will do a second injection. Most people will get at least a 12-month response and relief of pain inside their knee joint and be much more functional during that period of time. It's not going to cure it forever. And I tell patients, it's not going to be the last thing they ever get done to their knee. I think when you're looking at tendons, we've certainly had our best success with lateral epicondylitis. Isolated rotator cuff tendinopathies do really well with PRP and actually even probably better with medicinal signaling cells or mesenchymal cells. Shoulders can be a little complicated by the fact that you need to make sure there aren't some, capsulitis issues or pain coming from their neck or other areas. But truly to have a partial rotator cuff tear or significant tendinopathy, a well-placed biologic, I think is a really good treatment option. A few other areas that we've had great success with and has been gluteus medius tendinopathy, which is the tendon on the outside of the hip that can get commonly overused in kind of middle-aged active people typically. And then there's some areas that are more challenging. Achilles tendons are challenging, patella tendons are challenging, proximal hamstring area is challenging. And I would be remiss if I didn't mention through this whole dialogue that, another kind of biologic, which is maybe a little bit different or a little different technology is the use of something called shockwave therapy, which is another way we can induce signal into tissue to try to let the tissue heal. And we've seen really good success. I've been doing that for the past couple of years in our clinics. We've seen really good success with a lot of these same tendinopathies without the need to put needles in them and allowing them to maybe even continue to be a little bit more active during the healing time.
Yeah, I can attest to that too. I saw it with my own eyes.
That's right.
Are there any advances that you're seeing in orthobiologics that you're pretty excited about? Even on the horizon that's coming up?
I often say that I feel like the field is moving a lot slower than I would have expected it to move. There are some companies who are doing studies looking at disease-modifying osteoarthritis injectable agents, more so than, first-generation PRP, which may be more just symptom-modifying and not really disease-modifying. So I think over the next 5 or 10 years, hopefully there'll be some off-the-shelf versions of these injectables that can really, help people and either prevent progression or actually induce some healing in the tissues. I think for tendinopathies, there are other tools coming on the market, some of which, I've been involved with that are helping us heal tendons in addition to PRP or in conjunction with PRP. And I think that technology will continue to improve over time. So I think over the next 10 or 15 years, there will be more and more things that we have done surgery on in the past that we can hopefully do in the office with physicians like you and myself and still give the same outcomes with quicker recovery and less complications.
And then just 2 more questions. I want to be respectful of your time here. Are there any considerations you would give to someone listening now that's considering orthobiologics that you would give advice or anything like that?
Yeah, for patients out there, I will say that there are lots of providers who are doing these treatments, some of whom are excellent and some of whom are probably not as well trained. I will comment on the fact that a lot of the places out there who are doing allogenic or the birth tissue products, the FDA, for the most part, has told us that we should not be using these in clinic at all. I am by no means saying there's no value to these products. But if you look at some of the research I've done and some of the research done by other folks, most of these products do not contain live stem cells. And I'm not sure they work any better than using autologous products such as your own blood or your own bone marrow or your own fat. So I would really have patients ask their doctors, those sort of questions, make sure they have experience with it. I would certainly consider getting second opinions and make sure the prices that you're paying for these, because we hear stories about people paying, $10,000, $15,000, $20,000 sometimes for these injections, which honestly, it's just more than I think anybody should be charging based on the literature available. So these are all important things to be looking at. And if it doesn't feel right to you and you don't really get the sense that you're in the right place, and then you're probably not. And you should probably get another opinion.
Yeah, that's fair enough. Thank you so much for your time, Dr. Mautner. You answered both my questions just there, so that's great. I really appreciate your time and thank you for being on.
Yeah, well, thanks for having me. I appreciate it. Good to see you as always.